Good evening, everyone. I'll try to keep it as informal as possible. So like we already spoke about in the group, right? This is to discuss lupus and how to go about with the journey of pregnancy. Uh, so these are some of the disclaimers. Like right? I'm a general practitioner. I'm not an expert, or I don't have expertise in handling both lupus and pregnancy, like how a rheumatologist would handle lupus or an OB/GYN doctor would handle a pregnancy, right? But nonetheless, this presentation will serve to give a basic overall idea of what are the different things that go on when a lupus patient decides to become pregnant, and what are the different complications that might come about, and how do doctors manage it. And yeah, so it will help you decide better when is the right time for you, and what kind of questions you'll have to ask your doctors. And rare scenario, sometimes if your doctor is making some mistakes, you'll have like a little bit of idea as to ask specific questions to them as to, okay, shouldn't we do this, shouldn't we do that, things like that, right? That is the purpose of this discussion. Whatever like medications that we discuss here, whatever tests and interventions we discuss here, please do not follow them without the proper guidance of your doctor, right? Your primary doctor. Definitely do not start or discontinue any of your medications. Do not start any new medications as well without proper consultation with your primary doctor. That is the elaborate disclaimer, and sorry for that. So we'll move forward. So before we do this, right, or yeah, from the next slide we can do that. These are some of the normal changes that happen in a woman's body during pregnancy. Sorry. So there will be a lot of hormonal changes, and those are like the beta HCG, progesterone, estrogen. These all go up and down during different phases of pregnancy, right? Beta HCG will be very high during initial stages of pregnancy. Progesterone will be very high throughout the entire pregnancy. Estrogen levels are fluctuant. A lot of hormonal changes. There are a lot of cardiovascular changes. There's a lot of increased blood volume because obviously, right, a new baby is going to be housed in the body, and whatever nutrition the baby requires, whatever immune cells required by the baby, clearance of the waste, everything is done by the blood vessels or the arteries and the veins of the mother. The baby's heart won't really pump blood. Mother's heart is what will do this extra pumping that is required. So there will be an increased blood volume during pregnancy, and there will also be an increased work on the heart because of the same reason. There's respiratory changes. So as the size of the uterus grows, right, uterus is where the baby will be during the pregnancy. So as the size of the baby increases, in the progression of the pregnancy, the size of the uterus also increases. This puts a pressure on the diaphragm. Diaphragm is a muscle that separates the chest and the abdomen, right? In between that, there is a muscle called diaphragm. So uterus, right, when it keeps on growing, it pushes on the diaphragm upwards. So, during some of the pregnancies, women definitely have difficulty in breathing, especially if it is a twin pregnancy or multiple gestation pregnancy. The size of the uterus can be very big, and this can cause difficulty in breathing. So these are all some of the normal changes we are still discussing. There can be changes in the in gut changes, such as because of the increasing levels of certain hormones, it has a direct impact on the gut. So there can be increased nausea. You might have heard that women carrying twins will have excessive nausea. We call it hyperemesis gravitarum. That's the medical term, right? Some people have complications because of excessive vomiting, such as they can have a tear in the esophagus, or they can have damage to the valve that is between the esophagus and the stomach, causing acidity even after the pregnancy is completed normally. So these are some changes that can happen in the gut. Obviously, there can be increased sensitivity towards certain food items or even smells. This can be very significant during pregnancy, to a level where uh, people who haven't been pregnant or men can't understand the severity or sensitivity to which women get affected by this. But nonetheless, it does happen. Sorry. So there are changes in the kidney as well because of increased blood volume. There are changes in the kidney, and since a lot of blood is being pumped uh, in the uterus, there are these arteries called spiral arteries. When there is no pregnancy, spiral arteries are the ones that uh, or in general, spiral arteries provide nutrition to the uterus. So when a woman is pregnant, the spiral arteries are the ones that will provide blood and clear wastes from the placenta. And when there is no pregnancy, spiral arteries are the ones which will, cause thickening of the endometrium, which is a layer which will be pushed out during the periods. So spiral arteries, they become expanded in size during pregnancy. A lot of different local hormones there cause expansion in the spiral arteries, so that the increased blood volume can flow freely to the uterus and the placenta. But sometimes there will be issues with the normal expansion, vasodilation of these spiral arteries, which can cause hypertension. Okay? So women who have hypertension before the pregnancy even started have an increased issue with this particular change, right? Because they already have hypertension, and you add more volume to the body. Obviously, that will further impact the tension that happens inside the arteries and veins, right? So there are some musculoskeletal changes. Obviously, you might have noticed that the curvature of the back changes very dramatically during pregnancy. Uh, all this is to accommodate the growing fetus. So yeah, and also there are some changes in posture that occur during pregnancy. So to accommodate this, a lot of musculoskeletal changes happen. And there is also increased demand for calcium during pregnancy. So uh, if you're already a little lower on your calcium before the pregnancy starts, right? And you're prone to developing low calcium levels because of, say, a vegan or a vegetarian diet, or generally there is low calcium in your diet, or there is osteoporosis, there are some hormonal issues in the body, various reasons that might predispose a woman to low calcium levels before pregnancy. Care should be taken to supplement more calcium and more vitamin D during pregnancy. And then there is decreased estrogen in the phase where the woman would have just given birth to the baby. Uh, so we call it postpartum period, right? So during that, estrogen levels go down. And estrogen is one of those hormones which is very important for the health of bones. So you can, make a guess that, because of this lowering estrogen levels after giving birth, the health of the bones can be affected negatively. So some precautions we may take to counteract this one. So now comparing this to, how does lupus affect these normal changes during pregnancy, right? So first of all, there is an increased risk of hypertension in patients who are diagnosed with lupus. So increasing blood volume in the pregnancy is one factor which already we discussed. And then if patients with lupus, they are already having lupus nephritis, this risk further increases because, there are a lot of mechanisms that the kidney uses in order to maintain a normal blood pressure, normal levels of certain electrolytes such as sodium and potassium, so that blood pressure doesn't go beyond what is safe for the body. So when there is lupus nephritis, there's an increased risk of hypertension, which is directly related. It is not because of pregnancy, but there's a direct risk of increase in the blood pressure. And then there is damage to the endothelial system, meaning there's a coating inside the arteries. We call it endothelium. This coating, right, it releases a lot of locally acting substances, which can increase the diameter. To put it in simple terms, increase the diameter of the artery when there is increased blood flow, or decrease it when there is low blood flow. So a lot of changes happen in the size of the arteries because of this endothelium secreting various substances. So there's autoimmune damage to this endothelial system in lupus. So this further impairs this mechanism of maintaining a normal blood pressure, and this can become a disadvantage during pregnancy. Right? There are these complications called eclampsia and pre-eclampsia, and generally this happen after 20 weeks of pregnancy. So because like we discussed in the previous slide, right, normally the spiral arteries which provide blood to the uterus, they undergo expansion so that a lot of blood can be supplied to the placenta. And when there is endothelial damage to the spiral arteries, right, this normal expansion cannot happen. So because of that, hypertension will happen first, and then it can progress into proteinuria. So when we see proteinuria along with hypertension in a pregnancy which is greater than 20 weeks, right, we call it pre-eclampsia. So which means that the pressure in the spiral arteries is so high that it is squeezing the protein out. Okay, so that is pre-eclampsia, and that is just a simple definition of pre-eclampsia. It can be, there are more complications that can happen because of pre-eclampsia. So do not mistake this. Pre-eclampsia can definitely happen in women who do not have lupus as well, but the risk of pre-eclampsia is higher in patients with lupus and they get pregnant. And then there is eclampsia, where pre-eclampsia then develops into eclampsia in a small percentage of patients who develop pre-eclampsia. In simple terms, eclampsia is basically brain damage because of increased blood pressure. So the consequences of increased blood pressure cause damage to the arteries which are supplying blood to the brain. And some of the warning signs that can present before eclampsia happens is, dizziness, very severe headache, confusion, loss of consciousness. All these things can happen just before eclampsia develops, even in women without lupus. But the risk of eclampsia is a little bit higher in patients who have lupus. Okay, so flares can happen during pregnancy, right? Because estrogen and progesterone levels go up and down during pregnancy, and this affects the immune system respectively, because a lot of immunomodulatory molecules in the body, which, either make the immune system become hyperactive or suppress the immune system. So the molecules which have both the effects, right, we call them immunomodulatory molecules. Surprisingly, vitamin D is one of such molecules, right? That's why it was used in COVID as well. So many of these immunomodulatory molecules, right, they change in the concentration during pregnancy, and certain times this can result in a flare, right? So pregnancy itself is a period in life where the immune system is a little bit different than the time when there was no pregnancy, because a new, you know, human will be accommodated within the body, right? Obviously, the immune system should not be too aggressive. Otherwise, it will not even allow the pregnancy to happen. Because even when small bacteria or virus enter the body, the immune system acts so, like, it alarms the immune system and we face so many symptoms. But here, during pregnancy, a baby is going to be housed within the body. So, certain molecules responsible for this immune activation, right? They get suppressed, while certain other immune molecules they get increased. Okay, in order to keep the baby safe from the infection, in order to keep the mother safe from the infection, all this. So, in women with lupus, right, these molecules can lead to a flare sometimes. Uh, so that is one of the things to be kept in mind. Joint health, a lot of different changes happen during pregnancy to the joints. One of them is like the joints become increasingly mobile. Okay, this can lead to imbalance, and then there's a higher demand for calcium. And in many patients who have lupus, right, they are prone to having low vitamin D, low calcium, and this risk of developing bad complications of bones, right, they can be higher when a loopy gets pregnant. Okay. And then there is pressure on the lungs from the uterus. Like the growing uterus can put pressure on the lungs, right? So in lupus patients who already have some kind of lung complications, right, such as if they have developed a pleurisy, if they have developed interstitial lung disease, if they are prone to developing pulmonary hypertension, there are even in our own group there are some patients who have noticed these complications, these lung complications due to lupus. And during pregnancy, when the uterus is pushing on the diaphragm, right, these complications can become a little bit more severe, right? So medications that are harmful to the baby, but they are important in the treatment of the lupus. Obviously, there's a conflict here. So some of the medications that can be harmful to the baby will need to be changed before a loopy plans her pregnancy. So, which means like, many times all the loopies don't get adjusted very well to these medication changes. You know, it would have been so difficult to find a particular regimen that works for them in the first place. And then after establishing that, changing that for the sake of planning pregnancy, it can be more challenging than what we can imagine. But nonetheless, medications that are harmful to the baby will have to be stopped. And then certain alternative medications which are safe for the baby need to be started. And then some time has to be given, like at least 6 months of this new medications, right? Before deciding whether, this is, you're safe with these medications and you're not having a flare, and you can safely progress to pregnancy, right? Preterm birth is another complication that lupus experience more often than women without lupus when they're going through pregnancy. Again, this happens because of the endothelial damage that happens to the arteries because of autoimmunity, and blood supply to the uterus might get compromised, not continuously, sometimes even for a short period of time. If blood supply to the uterus is not optimal, it can lead to bad health of the placenta and the baby. And when an OB-GYN doctor, an obstetrician gynecologist, they notice that the baby is not progressing in the manner that the baby is supposed to progress during a pregnancy, right? They'll decide, okay, let's deliver the baby and we'll continue the care in a neonatal ICU, like that. So the chances of preterm birth is also higher when you go into a pregnancy with lupus, right? I hope I'm not going very fast. Until now, is everything clear?
Yes, it is clear.
Clear.
Yes.
Hmm. So as we go forward, if there are any doubts, or if I'm going too fast, or if any of the terminology that is being used is very complicated, please don't hesitate to interrupt me. So we'll go forward. Yeah. So now let's just assume that you're planning for the pregnancy, or if you don't want to get pregnant and you want to, like, you're on medications that are dangerous for a pregnancy. Generally, the way to prevent a pregnancy is through barriers, like, condoms are the most common barriers that are used. Uh, and then there are progesterone based pills and devices. Devices meaning there's an implantable device that can be put here, in the hand under the skin, which delivers progesterone in a very slow and long term fashion, which is, it can be left there for many years and it will not, lead to a pregnancy. It will protect you from a pregnancy. And there are intrauterine devices such as Mirena and other progesterone based intrauterine devices, which are inserted into the uterus. So, progesterone based pills, right? Uh, Such as a morning after pill, what we commonly get as I pill. It is a progesterone based pill. It is safe to use during pregnancy, but nonetheless, it has its own disadvantages and um risks that it can present. But if you do get pregnant and you're on medications which are not safe, uh, during pregnancy, obviously you can use emergency contraception. And if you wish to prevent the pregnancy altogether, there are implantable devices that can be used, and obviously, barrier methods such as condoms and diaphragms. They are what most women use anyways. So if the answer to this question, whether if you want to get pregnant, if the answer is yes, then these are the things that you need to consider. So is your lupus in remission, right? If it is not in remission, then you have to get it into remission first, right? This can be achieved either by changing the medications that you're already taking, because obviously they didn't get you into remission, changing the dosages of medication, trying different regimens under the care of your rheumatologist, and you have to get yourself under remission, right? You should not be on an ongoing flare, shouldn't be the case if you're planning for a pregnancy, right? And then medication changes, like we discussed above. You should, get a medication review with your rheumatologist, and certain medications that are not safe for the baby, they'll be replaced by some other medications which will achieve the same thing, and we'll have to wait for 6 months to see whether you know these new medications are serving the purpose of preventing a flare and keeping your lupus under remission, right? So you see, if you if you start planning for the pregnancy, right, it might take 6 months before you actually are sure whether you can progress forward or not, right? And then screening for comorbid conditions such as antiphospholipid antibody syndrome, if there is any hypo or hyperthyroidism. These things should also be done before you decide to plan for pregnancy, because these things might make it very difficult for pregnancy to happen. And if pregnancy does happen, it might you know cause some complications such as miscarriages, spontaneous abortions, increased risk of hypertension when there is high hyperthyroidism. uh, there might be increased need, there might be a need to increase the dosage of certain medications which you are taking for other health issues. All these things, right? It should be addressed before you make the decision to progress into pregnancy. So, hence, it will be part of the pre-conception counseling, right? And then we'll have to check for your cardiovascular health, obviously, right? Because heart will be working very hard during pregnancy. So, lipid profile and body weight, these things are commonly, if there is high cholesterol levels, medication will be started before you actually progress into pregnancy so that it can be corrected. If the body weight is very high, uh, it affects the pregnancy in some negative ways. It is not good for the joint health as well during pregnancy. There are increased chances of developing diabetes and hypertension during pregnancy if the weight is very high. So, getting the weight to an optimal level is also one of the goals of the preconception counseling. Renal function, right? If the patient has nephritis, uh, what, like, the nephritis should, the health of the kidneys should be optimized before you progress into pregnancy. So if there is no nephritis, the goal will be to prevent nephritis due to a flare during pregnancy. If there is already a nephritis, then the goal would be to stop its progression before you enter pregnancy. And if it is not possible to stop the progression uh, of the nephritis, right, then the only option that would remain is to plan for a pregnancy after your transplant, right? It is not advisable to go ahead with pregnancy during dialysis in case the nephritis was unable to be stopped. So once transplant has been done, you'll have a waiting time of at least 1 to 1.5 year before you can start planning for a pregnancy, right? So, and then if there is diabetes, that should be addressed before you progress into before you progress into pregnancy. And then if there is already osteoporosis due to various reasons, then that has to be corrected before you progress into pregnancy. Or, like, additional precautions will have to be taken while you're pregnant if you're already having a low density of the bones. Mental health, right? Pregnancy, obviously, it is not very easy to go through a pregnancy. And if you're already depressed, right, things such as miscarriages, spontaneous abortions, a lot of complications during pregnancy can become extremely difficult to handle uh, during pregnancy. So, if you're having mental health issues, preconception counseling is the time when decisions will be made to consult a psychiatrist or to get your depression under control, uh, by starting an antidepressant which is safe to continue during pregnancy, for example, right? uh, and also postpartum period, which is just after you give birth. There's the we call this period postpartum period. It is a very sensitive time for mental health. Many women undergo postpartum depression, and the risk is same for lupus. So addressing the severity of depression before you start your pregnancy itself will be a very, very good idea, right? And then there is genetic counseling, right? So we have to discuss the possibility of lupus or other autoimmune conditions happening in the newborn, born to a mother who has lupus, versus there's a condition called neonatal lupus, which is which happens to the children being born to mothers who are diagnosed with lupus and have these antibodies, anti-Ro and anti-La, right? If a loopy has these particular antibodies, right, there is around, 25% chance of the newborn developing this temporary condition called neonatal lupus. It might sound scary, but this is just temporary. It resolves on its own. So there is a 25% risk that child born to a mother with lupus, right, will have symptoms of lupus as soon as he or she is born, but it will go away on its own in a few months of growing up. But however, there's a out of those 25% children who develop neonatal lupus, right, 2% of them can develop a complication called heart block, right, where the walls of the heart, rather not the walls, but the system in the heart, which is responsible for maintaining a normal heartbeat and normal rhythm of the heartbeat, right? Sometimes that gets attacked by the autoimmune cells, these anti-Ro and anti-La antibodies. They go and cause damage there. And when that happens, right, the baby will require an artificial pacemaker being implanted into the heart, right? There is a treatment for it, but obviously it is a very scary situation to go through, right? So just to recapitulate, right? If the if you're willing to get pregnant while you're on lupus, you should be in remission. Medication changes should be done 6 months before you consider going forward with the journey of pregnancy. If there are other health issues such as antiphospholipid antibody syndrome, thyroid, issues with thyroid, diabetes, even osteoporosis, mental health conditions, all of the other health issues should be optimized before you proceed with the pregnancy. Cardiovascular function, the heart health and the kidney health, both of these have to be as perfect as possible. And if there is already nephritis, care should be taken to ensure that the nephritis is not progressing further when you decide to get pregnant. And then yeah, being aware of the risk of neonatal lupus is a part of genetic counseling that happens. And I forgot to discuss this, the possibility of the child developing lupus later in life or other autoimmune conditions later in life. The risk of this is similar to women who get pregnant without lupus, meaning whether you get pregnant with lupus or without lupus, the possibility of developing lupus or other autoimmune conditions later in life, the child developing it, the risk is very similar, right? Although there is a genetic component involved in the development of lupus, uh, which causes a very slight increase in the risk of the child developing lupus later in life. But that is very, very small increase in risk compared to the normal population. So you shouldn't be scared that, okay, what if later in life my child might develop lupus or other autoimmune conditions because of my lupus, right? The chances very similar compared to women who don't have lupus. Okay, so if these things are ensured, while it is scary to go ahead with pregnancy having lupus, if these things are ensured, majority of the women have a very eventless pregnancy and the baby will be born very healthily, right? So it is very, the data that is there, which I'll share with you later, is very encouraging. So if these are the things that should be followed and the pregnancy will go very smoothly. And also you should be prepared to face complications, right? If there's a miscarriage, if there's difficulty getting pregnant, or if there's a preterm delivery, or if the baby ends up developing neonatal lupus, all these things, there are possibilities, right? So a mental preparation is also important before you progress into the journey of pregnancy, right? So any questions here? I guess no questions, right? Am I audible? I hope I'm not disconnected, right?
Yes.
Yeah. Everything clear until now, right?
Yeah.
Okay.
Nitin, just a question.
Yes.
So, when you say that lupus is active or not, so does it depend on the dsDNA report?
Yes, absolutely. So That's a good question. So, how do we know whether lupus is in remission, right? Because sometimes, even when there are no symptoms going on, there might be a flare coming up. So, how do
Yeah.
we differentiate that? Is by getting an anti-dsDNA profile, which is very predictive of an ongoing flare or a flare that might happen very soon, right? If anti-dsDNA is in the normal limit, then nothing to worry. Some other
Okay.
blood tests which will give us some clues are ESR, CRP, and complement levels C3 and C4.
C3 and C4. Okay.
Yeah, these three, if they are in the normal levels, then nothing to worry. But if they are in an increased level, then there will be some medication changes to get them into the normal levels, so that the risk of the flare will be further reduced. Right? When all of these tests, dsDNA, ESR, CRP, C3, C4, all of these are in normal limits, then you can be very sure that you are under remission currently. Right?
Okay.
ANA we use only for diagnosing lupus, right? It's just like an initial diagnostic tool for lupus, but it doesn't give us much clues into whether you're ongoing a flare or if there's a possibility of a flare coming up soon. That information we cannot get from the ANA itself. So, yeah, dsDNA will be a very good starting point.
Okay. Okay. Thank you.
Yeah. So going forward, so let's just say you got pregnant and everything else was assured. So what to expect now? So first we confirm the pregnancy and early assessment will be conducted. Again, you'll be checked whether your dsDNA, CRP, ESR, C3, C4, all of these are normal or not. This will be checked by your rheumatologist. Prenatal care will be initiated, and then uh, many of the vaccines, right, which are used also during women, also during pregnancy without lupus, they will be administered routinely in order to prevent infections during lupus, right? And then medications will be reviewed as part of your first trimester. So again, if there are any medications that are not safe, by mistake, if they have been started again, or by mistake the patient is taking them, okay, an assessment will be made whether to continue this pregnancy or, you know because sometimes it's not safe to continue pregnancy with certain medications. You'll have to try again after discontinuing them. So there will be this checkpoint at that, you know when you get a confirmation of pregnancy. There will be a review of medications again, and then as you progress through your first trimester, right, which is until 13 weeks of pregnancy, this will be done, once in every month, your markers will be checked just to make sure that a flare is not nearby. uh, and in case, after getting pregnant, the dsDNA is going up or C3, C4 are going down, ESR, CRP going up, that time a decision will be made to increase the concentration of prednisone or increase the concentration of azathioprine. Like, the uh, the medications used to treat lupus, the dosage might be increased, okay, just to reduce the risk. So hypercoagulable state means the risk of getting a clot. So this is increased during pregnancy, but it is further increased in antiphospholipid antibody syndrome. And even with even when this APLA is not positive in lupus, there is still an increased risk of uh, developing clots here and there, because there is damage to the endothelial system, right? Endothelial system often prevents or manages blood flow in such a way that clots do not happen. So there's an increased risk of clots. So often tests like D-dimer might be done just to evaluate whether you are at an increased risk of developing a clot. And most of the times, whether there is positive APLA or not, a low dose aspirin will be started at the start of your first trimester, because this will really reduce the risk of developing any clots. And complications related to the clots, such as say TVT or a stroke, right? Some scary things might happen because of a clot, and there will be more than usual monitoring of a clot when you are getting pregnant with lupus, so that complications can be prevented. Obstetric ultrasound and fetal monitoring. This is done even to women who are who do not have lupus, but this will be done in the first trimester, just for your reference, right? Fetal monitoring can be done through this first trimester ultrasound, where they look for a lot of different parameters just to see that like the baby size is progressing normally, the location of the implantation is proper, okay, the location of the uterus is proper. All these things will be assessed in the first trimester, so that because it is still first trimester, if something drastic is going on, it can be terminated without having to go through a lot of different things and then experiencing a lot of harmful complications, right? So moving on to the second trimester, right? A lot of the things that were done during the first trimester will be done here as well. But one important thing is hypertension monitoring during the second trimester, because after 20 weeks of pregnancy, right, if the spiral arteries in the uterus, they have not undergone proper expansion, hypertension will start after 20 weeks of pregnancy, right? We call it gestational hypertension, meaning the patient did not have any hypertension before they started pregnancy. But now, after 20 weeks of pregnancy, they suddenly start having hypertension. Because this hypertension can progress into proteinuria, which we call preeclampsia, and seizures, which we call eclampsia, right? It is very, very important to monitor hypertension very regularly during the second trimester. This is done anyways to women without lupus as well, but this will be done more regularly and more rigorously when you have lupus. And it is important to do this because not just eclampsia and preeclampsia, many other events during pregnancy, right, such as preterm birth, intrauterine growth restriction of the fetus, meaning the normal increase in size as the pregnancy progresses, right? That should happen, will not happen many times when there is hypertension. Again, this is because blood that is supposed to be delivered to the baby is not being delivered as effectively because of the hypertension, right? So hypertension monitoring and taking necessary steps to bring that hypertension under very strict control. Obviously, there are medications that are very tailored to be used during pregnancy, such as a methyl dopa and labetalol. These are some medications that we use during pregnancy if hypertension starts. So these medications will be used to get hypertension under control. And as long as the hypertension stays under control, nothing to be worried. Pregnancy outcomes will be very good. There'll be fetal anatomy ultrasound that is done. This is done, in all women and in patients with lupus, right? Some extra details will be important, such as whether the growing baby has achieved a proper size, or because of some endothelial autoimmune issues, the baby is also being affected. Okay, and there will be clues to whether baby has some genetic disorder going on, uh, congenital disorders, right? Because all that will be known in fetal anatomy ultrasound. Like basically, if the baby is born later and it has some disorder which the baby will have to handle lifelong, right? Such as Down syndrome, other genetic issues that are, very sad for both the patient and the mother to go through. So fetal anatomy ultrasound is done around 18 to 20 weeks of pregnancy, so that a mother can take a proactive decision whether to continue with the pregnancy if there are some scary complications going on, right? Uh, and then renal function will also be monitored, because second trimester is very much known to cause complications such as nephritis, and hypertension. All, if renal function is bad, uh, it can lead to hypertension and it can lead to more complications. And if patient has nephritis, uh, it will be checked whether the nephritis is progressing further during second trimester. And if it is progressing further, an important call will have to be made whether, is it safe to continue pregnancy at this point? Because in many different countries and in India and many other countries, it is okay to get an abortion until 24 weeks of gestation. Again, sorry if I'm being very insensitive about the topic, right? It is a very traumatic process to undergo. Whatever the reason for the abortion might be, it is extremely traumatic for the mother and the family, for that matter, to go through. But again, there will be a decision to choose to terminate the pregnancy if the nephritis is progressing at the second trimester, right? The thrombotic risk, hypertension, the medication review, these are common to the first trimester as well. That there will be an assessment of whether there's increased risk of developing clots, if there's any medications that can be added in the second trimester in order to control the lupus itself, but at the same time it shouldn't be harmful for the baby, right? Some of the medications used in the first trimester will be unsafe during the second trimester, so these changes will be done timely, right? And then moving on to the third trimester, the final trimester, right? Again, a medication review will be done where some of the medications used in the second trimester might not be safe to continue in the third trimester, right? So those will be discontinued. New medications might be added in order to control some of the complications that have risen during the second trimester, right? Blood pressure will be further controlled properly, uh, meaning it will be monitored more rigorously during the third trimester. And if there are any signs of preterm labor, right, some interventions can be taken in order to prevent the labor from happening. For example, by giving progesterone injections, right? Progesterone injections tend to uh, stop a preterm labor or prevent it from starting. Right? Fetal growth monitoring, just to make sure, right, whether the baby is growing to the proper size that is expected in the third trimester. This will happen. And then finally, if there are no like no drastic things are happening, no complication to the mom and baby, absolutely awesome news. You will be prepared for the labor, and labor will be induced at 38 weeks. And if the mother doesn't want the labor to be induced and she wishes to, let it happen, then we can wait until 42 weeks for the labor to happen spontaneously. And if labor doesn't happen at 42 weeks, it can be induced again. And then there will be a decision whether to, undergo a normal spontaneous delivery versus a cesarean section, right? A normal delivery versus a cesarean section. That is also like an important decision to be made during the third trimester. So these are, the sequence of events that happen during the 3 trimesters when you achieve a pregnancy. Again, so just to recapitulate the information that we have discussed until now, right? First, you have to get ready for the pregnancy by controlling your lupus and controlling the other health issues that might be happening, right? After that, once you enter the pregnancy, as you know, certain complications might happen, certain medications might have to be discontinued or modified, and the doctors will be ready for that, right? They'll be ready to do that. You will be monitored regularly to prevent a lot of the complications, and there will also be a possibility where you'll have to take a drastic decision to terminate the pregnancy because it is not looking so good for your own health if you move forward with the pregnancy. So that might also come up, right? So these are the 3 trimesters. And then see, this slide gives you a summary of how many visits you will have to make to the hospital. So once you get confirmed with the pregnancy, right? Once in every 4 to 6 weeks, you'll have to visit your rheumatologist, right? Every month, once every month, you'll have to visit your rheumatologist, and every month you'll have to visit your OB/GYN doctor, obstetrician, until week 20, right? After week 20, you'll have to visit once in every 2 weeks, meaning twice a month. And once you cross 28 weeks, you'll have to visit every week, okay, until you deliver the baby, right? So every month, and from the start to the end of your pregnancy with a rheumatologist. And with OB/GYN, the frequency gets more and more frequent as the pregnancy progresses, right? And if there is a chance of a flare, or if a flare ends up happening, or if complications of such complications of the flare, such as pleuritis, nephritis, any of the complications of lupus in general, if they happen, then instead of once in every month, it'll be most likely it'll be once in every 2 weeks. Okay? And every time you visit, right, monthly, you'll have to get blood count, uric acid, urea, creatinine, electrolytes, liver function test, urinalysis, spot urine creatinine ratio, complement levels, and dsDNA, right? Even women who do not have lupus also get a lot of these blood tests when they are visiting for their prenatal checkups. But for patients with lupus, right, there are some additions here, right? And then ultrasound, right? Once in the first trimester, once in the second trimester. Those are very important. And once it will be done in the third trimester as well sometimes. So the fetal surveillance tests, right, such as an NST, for example, right? There are some things the OB/GYN doctor will do in order to check for the health of the baby, right? So it will be done weekly from the 26th week. Okay? So if there is anti-Ro or La antibodies, which increase the risk of neonatal lupus, right? Again, that is a temporary manifestation which will go away on its own, except in 2% of patients who develop the complications of the heart. If there is anti-Ro or anti-La antibodies, right, there will be more, fetal surveillance tests that happen just to make sure that heart block doesn't happen in them. Okay. Pre-eclampsia and eclampsia, anyways, it is very important to prevent those things, whether you have lupus or not. So, but when you have lupus, right, Doppler study will be done more frequently compared to a pregnancy without lupus, so that this complication can be prevented. And then intrauterine growth restriction, right? So more focus will be given as to the the growth curve of the baby inside the uterus, whether the baby size is progressing as it's supposed to, and if the size is not progressing properly, then the OB/GYN will take some steps in order to ensure better growth as much as possible, whatever is in the hands of the doctor, right, and whatever is in the hands of the mother also. Those things will be optimized to make sure that baby size will be fine. Moving forward, so there is this challenge that happens during pregnancy. So how do we differentiate a flare from normal symptoms of distress that happen during a pregnancy? Because pregnancy doesn't go very smoothly for all women, right? Majority of the women have some symptom or the other which causes distress to them, and many of the symptoms that indicate flares in lupus, right, they can mimic these symptoms. So No matter whether it is because of a flare or whether it's because of normal changes during pregnancy, there might be increased visits to the rheumatologist when symptoms occur. Again, the increased visit to the rheumatologist is definitely something which can cause a lot of inconvenience and distress, right? So, for example, swelling of the joints and joint pain, because a lot of the ligaments they loosen up in order to accommodate the different changes in curvature during the pregnancy. Uh, this can happen during a flare as well, right? Joints can get swollen, and joint pain can happen during a flare as well. So whenever joints get swollen or whenever joint pain happens, lupus, they tend to get scared, like, oh god, this might be because of flare. But more often than not, it's because of the changes that are happening during the pregnancy itself. Nonetheless, you will still have to visit a rheumatologist just to ensure that this is not due to a flare. Swelling of the hands, feet, ankles. Okay, increased fluid retention can happen during pregnancy. There is this thing called pregnancy blush, where increased blood flow to the face can cause red colored face, which can very much resemble the malar rash, the butterfly rash that happens during lupus. There can be patchy hair loss during pregnancy, uh, which can be very, like, common during pregnancy, but it can also suggest a flare. There might be fatigue, there might be shortness of breath, fever. Fever again might be because of an infection during pregnancy, or it can suggest a flare. So, and again, there might be proteinuria when there is already nephritis present, right? So, is this, you know, proteinuria during nephritis, or is it like, preeclampsia coming up because of hypertension, right? Differentiating these two will also become a challenge. Like you can see, right, a lot of the symptoms that can suggest a flare will have to be differentiated from symptoms that happen during a pregnancy, and majority of this differentiation will be done by a expert rheumatologist who has experience handling lupus going through pregnancy. Okay. And then just to give you an idea, right, which medications are safe during pregnancy, lupus medications which are safe during pregnancy versus which are absolutely, bad for the baby and will, cause negative outcomes and hence need to be discontinued, right? Your, prednisone, which is very, very commonly used, is allowed during pregnancy. It's allowed when you're breastfeeding the baby as well, right? But lowest possible dose that is enough in order to prevent a flare, that is what will be uh, used during pregnancy. If you're having a very high dose of prednisone before you start your pregnancy, the dose will be reduced significantly, and 6 months of time will be allowed to see whether this low dose is enough to prevent a flare or to keep your lupus in remission. NSAIDs, right, such as ibuprofen, naproxen, mefenamic acid. Surprisingly, many of these medications are still used in lupus. Some lupus can tolerate them, and lupus who have nephritis, they should absolutely stay away from them. The decision of the use of these pain medications, right, is purely the decision of the rheumatologist, right? But in general protocol, these are okay, right, during the first and second trimester of pregnancy because of back pain, because of headaches, whatever, right? For pain control, they can be used during the first and second trimester of pregnancy, but not during the third trimester, right? And they're allowed in during breastfeeding a baby. However, like, generally they are not used, especially when there is nephritis. Azathioprine, cyclosporin, tacrolimus, sulfasalazine, right? These medications are allowed during pregnancy, and low molecular weight heparin in order to prevent clots, right? It is also allowed. So as you can see, right, prednisone, azathioprine, cyclosporin, tacrolimus, sulfasalazine, low molecular weight heparin, all of these medications can be used in order to get your lupus under remission and progress into a pregnancy without any fear, right? There are a lot of options is what I'm saying. And then methotrexate, cyclophosphamide, mycophenolate, warfarin, these are not you know safe during pregnancy. And as you can see, methotrexate, right, 6 months before a planned pregnancy you'll have to stop it. Cyclophosphamide, which is endoxan, right, you'll have to stop at least 3 months before a planned pregnancy, right? Mycophenolate, which is like one of the very common medications being used by lupus in our group, right? It has to be stopped at least 6 weeks before a planned pregnancy. So like this gives you an idea, right, what medications are safe during pregnancy, what will have to be stopped 6 months before, like that. Like if say methotrexate has to be stopped, most likely the replacement will be sulfasalazine. Right? If cyclophosphamide has to be stopped, most likely it is azathioprine, right? That will be replaced, like that. And rituximab, right? At least 12 months before a planned pregnancy, right? This is the biggest one. So if you have taken rituximab in the last 1 year, right, you should wait. You should give it some more time in order for you to start planning your pregnancy. Okay? So one medication that is not mentioned here is low dose aspirin, right? 81 mg aspirin, which we commonly start in patients with antiphospholipid antibody syndrome. But even without APLA, it is still started when you are in the first trimester, just to prevent the complications that happen due to clots. Okay. The source of this, right? I've mentioned the very wonderful study done by a lot of these doctors here. It was done in 2014 and they kindly tabulated these results for us. So I'm using it from their study. Right? Now, before we start discussing the research findings in various parts of India, right? Do you have any questions for me until now? I'll take that as a no. So we'll hope everything is clear until now, right? Hope it is not a lot of information overload until now. Yeah. So a study was conducted in Karnataka. And as you can see, right, the study was conducted by many of the doctors we actually know very dearly here in Bangalore, right? Dr. Ramesh Joyce, for example, some patients are consulting him. That is Dr. Benzita Pinto, Vinita Shobha, Vijay K. Rao, you know, Vasudha Bhatt. All these doctors, right? Many of them are listed in the recommended rheumatologists in the file which we have in the group as well. So these doctors, which are very known to us, conducted a study. They considered 121 pregnancies, which happened in 80 patients. There were 80 lupus, but some of them got pregnant more than once, and they were enrolled in the study. And this study happened over a period of 5 years, right? And most of the patients who were participating in the study, right, were in remission, right? Out of 109 pregnancies, 121 pregnancies, 109 of them were patients who are going into the pregnancy while they were in remission. You can see, right, there is still 10% of pregnancies which entered a pregnancy when they were not in remission, right? Some of them still will go pretty fine, but why take the chance? Antiphospholipid antibody was seen in 45 pregnancies out of 121, right? uh, History of lupus nephritis was noted among 29 pregnancies out of 129. Right? So you can see that even with the APLA antibody and lupus nephritis, still a good percentage of patients, they went into pregnancy and they enrolled themselves into the study. Right? And maternal complications were 32%. And the main type of maternal complications happened were due to hypertension. Okay, not even due to lupus. This is very independent, right? That is mentioned in the study. Hypertension during a pregnancy, whether there is lupus or not, it will lead to complications. Okay, so if lupus progressed into pregnancy and it developed hypertension, the rate of complications was much higher. If there was no hypertension, great. Right? So 32% of the pregnancies, like 32% of the complications were due to hypertensive disorders. And as you can see, right, 19 out of 121 pregnancies had hypertensive disorders of pregnancy, HTP, right? So not a very big number, right? Only 19 out of 121 pregnancies, the mothers actually developed hypertensive disorders, right? Hypertension, preeclampsia, eclampsia, these are all the hypertensive disorders. So a small number, and among those 19 pregnancies, only 32% of them experienced complications. This is the mother itself undergoing complications, right? And now looking at the baby, right? So when it comes to complications in the baby, right? Spontaneous first trimester abortions were the majority of the complications. 58%, right, of the complications of the baby were spontaneous first trimester abortion, meaning the baby will be aborted automatically, without uh, doing anything to cause that abortion. Spontaneously, the pregnancy will stop. Those were the majority of the complications, right? Which is not very scary compared to a lot of other complications, right? I would argue so. Still very sad and traumatic, considering you planned for a pregnancy for such a long time, you underwent a lot of medication changes, and when a medication gets terminated in the first trimester itself spontaneously, right? So it's a huge disappointment, but you can start trying again almost immediately. Uh, for the next attempt at pregnancy, right? Now prematurity was like out of 121 patients, 121 pregnancies, 24 pregnancies resulted in premature birth, and 14 out of 121 pregnancies resulted in a stillbirth. So stillbirth means baby unfortunately couldn't survive the pregnancy, right? And prematurity is baby was born sometime before 38 weeks of gestation, or 38 weeks of pregnancy, right? So like you can see, right, stillbirth, very, very small percentage of, still very traumatic, but you should see the percentage. Out of 121 pregnancies, 14 were stillbirth. And stillbirth does happen in women who do not have lupus as well. Okay, it is not very specific to lupus, but when you have lupus, 14, this is the percentage of stillbirth, right? And 20% chances of prematurity, and then there is 16% chance of first trimester abortions, right? So as you can see, there's a chance of the baby getting spontaneously aborted, um, being born still being born premature. There is a chance, but it is very encouraging to know that the chance is not very, very high. As long as you take all the necessary care that is required in order to ensure smooth pregnancy, these will not happen. Okay. Hypertensive disorders of pregnancy is very strongly associated with stillbirth and prematurity, right? And is independent of active lupus, meaning this is not just for lupus. Even other women, right, who do not have lupus, and if they develop hypertensive disorders, they have increased risk of stillbirth and prematurity. Uh, there's 4% chance of experiencing a flare during pregnancy. Very low, very low. And even when you experience a flare during pregnancy, it's not like all the 4% of patients will have some negative outcomes, right? Out of 4%, some patients will be unable to control the flare even after changing the medication dosages, or even after substituting the medication to something stronger, during that time, an unfortunate decision will be made to, terminate the pregnancy and get the lupus flare under control using, like, stronger medications which are not safe during pregnancy, right? So, like, you can see, use of hydroxychloroquine HCQS was associated with a reduced risk of flare. So generally, whether the loopy is on HCQS or not, when they start the pregnancy, it is a good idea to start them on HCQS according to the study, right? Uh, So this is another study from Portugal, right? Like you can see, a lot of the statistics are very, very encouraging. Out of all the 215 pregnancies, right, 84.2% of them were successful, meaning live births. Baby survived the pregnancy, and rest 15% because of one or the other reason, the baby couldn't make it, right? Again, this, like, the approximate 15% of chance of the baby not making it to pregnancy, it is not specific for lupus. It is the risk still exists for a woman getting pregnant even without lupus. But when we look at research, this is what we have to be prepared for. 84% of the pregnancies were successful, the rest were not successful, right? There was some sort of adverse pregnancy outcome in 41% of patients, right? See, the adverse pregnancy outcomes can vary between something very mild, uh, such as, like, baby's weight is not uh, progressing properly, or developing hypertension, premature delivery. All these are adverse pregnancy outcomes. It doesn't mean that pregnancy just failed, right? Means that, like, there was some adverse event that happened, and patients had to take up some form of intervention under their doctor's care in order to mitigate the effects of that, right? There was a miscarriage rate of 15%, right? Preterm delivery rate of 15%, like, still very encouraging, because these percentages are very similar to women who do not have lupus as well. Preeclampsia and fetal growth restriction, 13 and 14%, right? Not very high. Okay, still majority of the pregnancies, they go on without preeclampsia and fetal growth restriction. And then neonatal lupus occurred in around 7.1% of newborns, meaning, as soon as the newborn is born, they have some symptoms of lupus, such as a rash, some joint flares, etc., which spontaneously goes away. And in another study, I saw that, like, it is close to 25% of this developing. But nonetheless, this is a temporary condition and it will go away on its own. And out of that, percentage of babies who get neonatal lupus, right, a very, very small percentage of them will progress to some form of heart issues. And, obviously, the OB/GYN doctor will do his or her best to really prevent this complication. But sometimes, it does happen, and the baby will require a artificial pacemaker to be implanted, right? Heart blocks do happen in women who do not have, like, in babies born to women without lupus as well. But neonatal lupus, unfortunately, increases the risk slightly. So here you can see, right, out of 215 pregnancies, there were two cases of babies who experienced a heart block because of neonatal lupus. Very, very small percentage, very close to, like, 1%, less than 1%. So this study was done in 2021 in Portugal. Very good study, because these many pregnancies being monitored in lupus, right, is a very rare thing. In the previous study which was done, right, still a very good study, because 121 pregnancies were monitored in lupus. So these are two good studies which will give you an idea of the different statistics of different events that can go wrong during a pregnancy versus go right during pregnancy, right? So this is just like, a simple summary for you. You have to plan your pregnancy and get lupus under remission. You have to change your medications at least 6 months before the time of planned pregnancy. And rituximab is the one you have to, like, have a gap of at least 1 year after rituximab before you plan the pregnancy, right? There's a very good rate of pregnancy being successful when lupus is under remission, right? You can, like, think of it as very similar to women without lupus. The rate of success of that pregnancy, right, is very high, almost comparable to women without lupus when you start the pregnancy with your lupus under remission, right? So majority of the complex to the mom who's going through the pregnancy are due to the lupus flare or due to preeclampsia, hypertension, lupus nephritis, antiphospholipid antibody syndrome. Majority of the complications to the baby are, first trimester loss of pregnancy, preterm birth, low weight of the baby, right? These are the complications. And hydroxychloroquine and aspirin are known to reduce complications in general, right? So even when patients are under remission, it is a good idea to put them in HCQS and aspirin 81 mg before they go through pregnancy, right? And finally, a multidisciplinary team of doctors is very, very important when you go ahead with the plan of pregnancy, right? A team of rheumatologists and an OB/GYN doctor are absolutely a must, right? And if you have nephritis, you'll need a nephrologist in your team as well, right? And when we go back, right, so you can see that, many of these doctors in Bangalore, Vijay K. Rao, Ramesh Joyce, Benzita Pinto, Vinita Shobha, all of these doctors are in Bangalore, right? They were part of this study. So we have, like, fortunately, we have a direct reference as to where to start your preconception counseling when you start, like, planning for pregnancy. Okay. So this is all the discussion. I hope everything was, clear, and I hope I did not rush through the discussion.